Well, it's good to be back in Minnesota virtually. I lived in Winona for 9 years, and now I'm in San Diego, so I get to live in San Diego, but I can pretend I'm in Minnesota right now, which is good. I'm a distinguished professor at California School of Professional Psychology at Lyon International University in San Diego. We have a PhD, APA-approved clinical program, and I had the health psychology track that program, so we get some great kids, including a lot of Twin City kids who come and study with us, and they're always some of my favorites. Excuse me. Our program encourages clinical work 1 day a week. So mostly I'm a professor 4 days a week, but I get to see clients on 1 day. It's a lot more challenging right now doing this virtually, but I've been doing it for years that way. And I like having myself in the clinic as well as teaching and doing research. And so I've been doing this topic for many, many years, and it's growing exponentially. It's been an exciting kind of a journey. And so I'll share a little bit with you tonight, and we'll get some questions after that. So let me share my screen. So this little graphic you see here is actually a student that lives in the Twin City and is back there right now finishing. She finished her internship, and she did a beautiful job of turning that EKG into breath, which says it all right there, but I think I better explain it a little bit more. So I'm going to do a quick background on the physiology behind this area, and then try to give you a little bit of an idea what's going on behind it, and then move into just a brief thing on measurement, which is quite a complicated topic, and then move into the actual biofeedback, which I think is the thing you're most interested in. The thing we want to focus on the autonomic nervous system is the modern view of the autonomic nervous system between the two branches, the sympathetic and parasympathetic branch, which I'm sure you guys all know. And in the parasympathetic branch, we focus mostly on the 10th cranial nerve, the vagus nerve. Very interesting nerve. I've written a paper, and some others have too, called The Nerve of That Disease, because this nerve is really plays a remarkable role in our health and well-being. About 80 to 90% of the fibers on that nerve are actually afferent, going to the brain, as opposed to from the brain, and that is always an interesting thing to look at, and we'll talk a little bit about that later. You can see from the architecture of the two that the sympathetic system is way more complex. It has preganglionic fibers, postganglionic fibers, actually has a couple of neurotransmitters involved in it. So the early fathers of physiology in the 1920s and 30s of modern physiology were really taken by the sympathetic nervous system, by its complexity and by its unique role in the fight and flight response. They sort of didn't realize that the neurotransmitters, the adrenergic neurotransmitters for that system are quite sluggish. It takes 2 or 3 seconds for anything to happen in that system. And that's actually a key point for us when we're looking at moment-to-moment regulation. So when I was in grad school back in the 60s, the focus was totally on the sympathetic nervous system, and everybody thought too much sympathetic, bad, that's all that counts. The parasympathetic was seen as a kind of housekeeping system, took over once the sympathetic went away. But now we know that actually moment-to-moment regulation is way more controlled by the parasympathetic system, especially the vagus, and that it ties into especially frontal systems in the brain in a very elaborate and unique way. We're going to focus much more on the sympathetic system. Modern autonomic physiologists, starting even 20 years ago, recognized this. This is a famous guy, Morrison from Australia, says the defense response, that is the fight-flight response, is just one of many activational states in the autonomic network. Those of us who've been doing biofeedback for a long time kind of got got a lesson in this early on because we would see people with cold hands and slow heart rates and loose muscles and no sweat gland activity. And then we'd see somebody with sweaty palms and warm hands and every combination, which is not how it was supposed to be. So we kind of learned that this is quite a unique system. The parasympathetic system has got more emphasis in health generally because it seems to be the stabilization system. Connects to acetylcholine, which is the fastest acting neurotransmitter in the body, and therefore is a real good candidate to understand how moment-to-moment regulation of the body occurs. Parasympathetic system stabilizes the cardiac membrane and helps reestablish homeostasis in the body. It's usually thought to, in most situations, exceed the sympathetic nervous system. Of course, there are exceptions to that, which we all see in our clinic, such as PTSD or strong stress-related disorders, and those represent a different kind of an issue. A very important concept for what you guys do and what I do is this concept of accentuated antagonism. It's been around for a long time, and there's quite a bit of empirical evidence for this, which is that vagal tone, the vagal efferent pathways, predominate over sympathetic tone at rest. Under normal physiological conditions, an abrupt parasympathetic stimulation will inhibit tonic sympathetic activation. Effects at rest during exercise. This is known as accentuated antagonism. I'll come back to this later, show you how important this has become, because the implications are that the vagus connect as a moderator, as a governor on sympathetic activation. And we know that in many of the disorders our clients have, are characterized by ungoverned sympathetic activity, even if it's in small spurts, without return to baseline. And so getting this system, and kind of the bottom line is going to be that the biofeedback technique seems to restore this accentuated antagonism system in a way that's quite beneficial for our clients. A lot of what we have now are due to two groups of researchers. Steve Porges is a good personal friend of mine, who I've known since the 90s and 80s and 90s, was the first to kind of look at the vagus and come up with these very widespread heuristic theories. If you haven't read Steve's books, they're really thought-provoking, not without controversy, but wonderful to speculate and think about, and it's led to so much productive research. And certainly has influenced my career tremendously, as well as my colleague Paul Lehrer, who you'll hear a lot about as we go. The other group, the concept of Steve's that I think really changed my whole clinical perspective was this concept of vagal withdrawal. And so I've really developed a whole mediational model based on this and this is the basis that we train our students basically, both in talk therapies and physical type therapies and biofeedback. The idea is that withdrawal of the vagal brake is probably a better model for stress than the sympathetic activity, which is sort of like the accelerator. And if you start thinking about it that way, suddenly stress takes on a very different meaning to you. Because if you were thinking about stress as a fight-flight response, that really has a very different implication than one as a vagal withdrawal or a break-off kind of response. And what we see is in the disorders that we see, largely, internalizing disorders largely are characterized by vagal withdrawal, not by excessive sympathetic activity. So you'll see how that works out as we go. Here's some examples of what it looks like. And I'll get into the details a little bit later, but this was actually a client of mine wearing an ambulatory heart rate and respiratory monitor. She had come to me for panic disorder. I had treated the panic disorder. She was panic-free, but she still had quite a lot of anxiety, especially around driving. Here she was on her way to see me for a meeting. Her husband was driving, and this is what heart rate looks like in normal activity. Heart rate was bopping along at a normal rate. You can see the ups and downs. Those are with breathing. And we'll talk about it in a minute. And right about here, she pushed the button, and later I find out she realized that her husband had been late to get her, and she was running late for the appointment. And this was a lady who was a legal secretary, was very fastidious and very punctual. And she was, being late was stressful to her. And this is what that stress looked like. These are just artifacts there, but you can see all of the rhythm in her heart rate went away, and it elevated quite a lot during that time. So there's an actual picture of vagal withdrawal. It's not pure because it also is accompanied by much more rapid breathing. But here's a laboratory version where the sympathetic was controlled with isoproterenol. A little hard to see because these little wiggly lines are supposed to be those ups and downs of the heart rate you saw a minute ago. And then these people get an atropine infusion. And when they get the atropine infusion, there's a paradoxical effect. Atropine is a cholinergic blocker. And so what we use atropine for is like for motion sickness and things like that, because those are parasympathetically mediated phenomena. So what happens when you first get a bolus of atropine is that it immediately stimulates heart rate variability, but then it kicks in. And here you can see a laboratory version of vagal withdrawal, where all of the variability, the wiggliness of the line goes away and it goes slightly. Clinical observation of this, which changed everybody's thinking about perimenopausal hot flashes, came when we have ambulatory records of heart rate variability from women who are perimenopausal, who would tell us when they're getting a hot flash. And here you can see that right at the onset of the hot flash, they have a tremendous drop in vagal tone. And then it comes back up and the hot flash is over when they come back to normal. And this is based on 21 women. And look at how nice those means fit the individual does. Very, very powerful data. The other person that we owe so much to is Julian Thayer, who's I'm currently working with a lot. And he's got a theory called neurovisceral integration theory. Excuse me. My afternoon nasal drip, sorry. In which he has used heart rate variability indices to look at the central autonomic network and really tie into the central nervous system in tremendous ways through looking at the peripheral aspects of heart rate variability. And his work is remarkable, and he's a phenomenal guy, great guy as well. And so I'll just leave you to, I would just highly recommend, here's a few of the references, there's a million more. Overall heart rate variability may index degree to which the medial prefrontal cortex guided integration system is integrated within the brainstem nuclei and directly regulate the heart. So it's a very powerful overall system. And now there's even developmental versions of the system, and it's also had a massive effect on the literature. So a little background of that. Now let's just look at what heart rate variability is. It's simply really defined as spontaneous changes in heart rate beat to beat. And it's related to autonomic and respiratory functions, as we'll see. But basically, the overall concept is simply anything that changes beat to beat to beat of heart rate. So the underlying physiology is both the sympathetic, parasympathetic, as well as the blood pressure receptor system, as well as some peripheral vascular influences. There is massive literature on heart rate variability measurement. High heart rate variability is associated with positive outcomes like emotion regulation, trait positivity, well-being, information processing, executive functioning. Low heart rate variability is associated with almost all morbidity, with mortality, with depression, anxiety, poor inhibitory circuits, and even with, unfortunately, with aging as well. So let me stop for a second, see if anybody has questions to that point. Okay, the main source of variability in heart rate is something called respiratory sinus arrhythmia, RSA. And it is a phenomena of the brainstem regulating the heart by alternating braking system. It's purely a parasympathetic system. When somebody has a vagotomy, or if animals have a vagotomy, they no longer have any of these rhythms at all. So as you inhale, there's a brainstem reflex that takes the vagal brake off. The heart chronically has a chronic level of tonic braking on it from the vagus nerve. If you don't have a vagus nerve, your heart rate would be about 120 to 130 beats a minute. So the fact that our heart rates are 60, 70 beats a minute means that we have tonic levels of braking going on in our system. However, when you inhale, that brake is taken off momentarily during the course of inhalation. And then when you exhale, the brake goes back on. And this produces a rhythm in the heart rate that you saw a minute ago of elevation during inhalation and deceleration during exhalation. It actually makes sense if you think about it. Why would you want your heart rate to be faster when there's no oxygen present in your lungs? So what happens is when you inhale, where the gas exchange is occurring in the lungs, the heart rate takes advantage of that by speeding up, getting that gas exchange going a little bit better. And then when you're exhaling, it takes a break and saves you about 350 to 400 million heartbeats in a lifetime. So it's actually a good deal. So when you're looking at heart rate, as you saw before, you see these peaks and valleys in the heart rate that correspond to respiration. And those are, in fact, the main source of variability for heart rate variability, but not the only source. You can see here that the two of them are in phase most of the time. When you inhale, heart rate goes up. When you exhale, heart rate goes down. And you can see that happening right in the pattern of the tachycardia rhythm. But there's another source, which is an interesting one, and it's a very important part of our biofeedback. It's called the baroreflex system. Turns out that we have rhythmicity in our blood pressure in our bodies as well if we're healthy. And our blood pressure tends to have rhythms not in the ranges of breathing, which tend to be 13 to 18 breaths a minute. Most people breathe normally. Blood pressure tends to be in the range of about 4.5 to 7 times a minute. Blood pressure goes up and down. This is an actual pressure diagram from an indwelling catheter, arterial in an artery, and you can see the rhythms of the blood pressure complexly, but you can see them at about 6 or 7 times a minute. So since the blood pressure is going up 6 or 7 times a minute, there's a feedback system to the heart from these, and it's called the baroreflex system. There's 2 sets of baroreflex receptors. There are one's in the aortic arch, and the other one's in the carotids. And they are these cool little cells that when they expand like a balloon, they're flexible. Then they increase nerve firing. And if they expand, that means the blood pressure is going up. They send an inhibitory message to the heart. And when they contract, and they contract below their normal level, then they send an excitatory level to the heart. So when blood pressure falls, they're sensed in the baroreflex, and it speeds up your heart rate to try and compensate. And when blood pressure rises, it tries to compensate, keeping it steady by inhibiting the heart rate. It turns out that you probably mostly know heart rate variability is a very good physiological trait, but blood pressure variability is not. You do not want blood pressure variability in a resting individual. It's very bad for you. So what this system does is it does its best to control blood pressure by monitoring and then feeding back into the heart rate system. And here you can see, if we take out the respiratory component, here's arterial pressure going up, and then slightly after that, you can see the heart rate going down. Here's the blood pressure going down. You can see just a little bit after that, heart rate goes up. And it has a little delay because it takes a while to get there, but it has that added rhythm into the heart rate. So now we have two sources of activity in the heart rate that create variability. There's a third one, which is an arterial wave, but it's too slow during our short-term measures, so we don't pay as much attention to it. For 24-hour monitoring, it actually is quite important. It's called very low frequency. All right, let me stop again and see if nobody has questions now. That means you're not paying attention. Nobody? Okay.
I think you're just doing such a fine job for explanations that everybody's up to speed.
Okay. I don't believe you, but that's fine. Okay, so we could spend hours and hours on the metrics that are involved here. I'm not going to do that because I don't think that's your main interest. So suffice to say there are two main metrics for measurement of heart rate variability. And the third one that is less common for us. The first one is very simple. It's called time domain measures. The easiest one to understand is called the standard deviation of normal to normal R wave, SDNN it's called. If you know what a standard deviation is, you know what this is. It just takes the interbeat interval between the heartbeats, creates every so many minutes, it creates a standard deviation of that, averages those. The more variability there is, the higher that number. 50 tends to be about the normal number, which would be about 10% of the normal changes in interbeat interval. And they go up and down from there. There's extensive norms available if you want them on these things. The one that's a little bit better to use that we use quite often is RMSSD, which stands for root mean square of successive differences, which is really the same thing with a better mathematical formula. It takes the difference between successive interbeat intervals, squares them, and then averages them together and takes the square root of those. So it stabilizes the data a little bit, gives you a little bit better stable number. The numbers tend to be a little bit lower than SDNN, but around the same level. Then there are many, many more that I won't talk about now. For us, it is important to talk about the frequency domain measures, and they're more complex. But I think so many of you guys know about EEG, so you'll know about frequency analysis. In this case, though, we're analyzing the frequency of those waveforms that we just saw in the heart rate. And we're looking for frequencies in the high frequency range, which are in the respiratory range, or in the low frequency range, which are in the blood pressure range. And then we might also look at the very low and ratio between those, but not as much as the other ones. The one we're most concerned with when people are breathing normally is the high frequency. And we take the natural log of that one because it's a highly skewed distribution. When we do that, we get numbers that range from about 0 to about 8, and they represent the role that the vagus is playing in that braking that I just described to you. So it's quite a nice measure if you're interested in vagal activity for the clients or for anybody else. However, remember that any of these measures only apply during normal breathing. So heart rate variability has hundreds of thousands of citations and all kinds of outcomes that we talked about already. I won't deal with that. It has the vagal brake has a specific application that we're studying very closely now in trauma. This was a student of Steve Porges's. And here you can see this was a large population of non-clinical population at a large YMCA in Chicago who were all taking health and fitness and yoga classes. And they simply asked them to give them a history of any childhood abuse, any adult abuse or no abuse. They asked them to sit quietly for 5 minutes. These are the vagal tone measures that you usually see. So 6.5 is a really nice average. And then they put them on an exercise cycle, got their heart rate up to aerobic range, and then gave them 5 minutes to recover and saw what happened with the 5-minute recovery. You can see the healthy, no abuse people actually improved a little bit. The people with some history of childhood abuse showed some vagal withdrawal, and the people with any adult abuse started off lower and really did not recover. So one way to conceive of psychopathology is as people with a compromised vagal brake. It doesn't bring things back into normality as quickly as it should. And if you think about most of the symptoms we see in our clients, they really make sense of those. And I'm just throwing that in just to give one little tidbit of how that works. Here you can see this is a program that's free to get called Kubios HRV. And in this one of our student study, we're looking at vagal recovery. This was a healthy individual. You can see here what their normal heart rate variability looked like, quite complex. Here's where we put them on the exercise cycle. And then we stopped and we let them recover. You can see it takes a little while, but pretty soon that person had really big peaks and valleys. So that means their vagal recovery system really kicked in to bring that heart rate right back down to where it was to start with. That's a nice, healthy vagal break. Here's a person, another person, an older person, still without a trauma history, but a little more compromised. They had quite a bit higher heart rate to start with, but they still showed the pattern pretty well and got down pretty well. So that would be a kind of an intermediate pattern. And here's a person with a significant trauma history and who had lower heart rate variability to start with. That was, they got up to a very high heart rate, and their vagal system was really struggling to bring it back down over the course of the 5 minutes. So that model is a kind of a viable model. We try to get that across to our clients and really get them to see why they should be doing the biofeedback that we're going to talk about. So let's talk about the main topic, which is the heart rate variability biofeedback. We like to say that it's a brand new idea that's 2,500 years old. It came about through myself and my colleague Paul Lehrer, who's out at Rutgers University. We were very active in the biofeedback community, mostly doing EMG, thermal, some heart rate itself. And just mainly we were interested in other signals, and we knew Steve Porges, and we thought, I wonder if we could begin looking at heart rate in an interesting way. And so we got a couple of the manufacturers to design some screens that would give us some information about heart rate variability, which was not easy to do at the time. And started doing this research probably about 21, 22 years ago. What we noticed, and had been noticed before, was that the 3 different frequencies that occurred during normal breathing, which are called high frequency, low frequency, and very low frequency, and I'll show you those in a minute, all go away when people breathe at a slow breathing rate between 4.5 and 7.5 breaths a minute. Paul went to Japan and studied Zen monks in the mountains of Japan. A couple of the rest of us were looking at yogis, and a couple of very experienced yogis that we hooked up. And in every case, we asked them to do what they do when they want to be centered, calm, and alert. And what we saw pretty much in every case was that they immediately went to a diaphragmatic breathing technique at one of those paces between 4.5 and 7. And whatever pace they chose the first time, they always chose it again. And described to us something that I'm interpreting to be something like a mindful mindset. I mean, they were telling us this in every kind of language you can imagine. So we weren't always sure what that meant, but it sounded like something like a mindful mindset. And when they did that, dramatic physiology occurred. Remember that the measures I talked about before don't apply when you're doing this slow breathing. I'm not going to really talk about the literature, but there is a nice meta-analysis fairly recently that analyzed all the literature to 2016 and concluded that heart rate variability was associated with large reduction in self-reported stress and anxiety. And there's a couple of more reviews after that as well. If you want to look at those, they're there for you to see. So the rationale behind the biofeedback, which we really developed pretty much afterwards, but Julian Thayer and Mara Mather, as a USC professor, recently just did a beautiful job of putting together a rationale for it. It took us a while to convince them, but once they did a better job than we did. And so the idea is that we know that this heart rate variability is strongly related to emotion regulation. And it could be just an association, but since we've seen so many studies where this changing this breath pattern has an effect on emotional regulation, as we just saw in that review, it looks like there's a reason to believe that something happens going up from the body into the brain that is more than just an association between the two. And when you do this, we think that it enhances functional connectivity, strengthen emotional regulation networks. Even if the heart rate variability is not highest, it seems to have an effect. And in our review, we suggest that heart rate variability itself influences brain and emotional function. Thought to increase the heart rate variability of breathing in about 10 seconds. This 0.1 hertz frequency is a resonance frequency, in which paced breathing induces oscillations in heart rate and especially high amplitude. So let's see how it works. Here's a pattern of heart rate of somebody who's been instructed to go into their resonance frequency for them, which is about 5.5 to 6 breaths a minute. And here you can see their heart rate was kind of just normally rhythmic here. They were breathing in a normal kind of complex way. Here we said, okay, start. The first inhalation was a little sloppy. The second inhalation again. All of a sudden we start getting these smooth peaks and valleys. I don't know if you can see it, but that person's heart rate's going from about 67 beats a minute up to about 97 beats a minute in each breath cycle. The frequency ranges, the ranges here are the normal breathing ranges. These are the blood pressure ranges. These are the very slow ranges. You can see that they all start going into a single peak in the low frequency range. During normal breathing, that wouldn't be good, but during slow breathing, this is actually a really good thing. So there's the 3 normal functions. So this is looking at all of the different rhythms related to your breath in the red. These are rhythms not related to your breath, but related to your blood pressure, and these are probably related to arterial changes, very slow rhythms. And so here you can see that pattern a little bit better than I showed you before. So we weren't sure what was going on with this. We had some idea, but we were very lucky in that Paul traveled to Russia. His son was a Russian studies PhD, now works for American AID. And he was stationed in St. Petersburg, and Paul went to visit him and said, well, I'm there, let's see what biofeedback's going on here. He asked around, and somebody steered him to this old tuberculosis sanitarium, and there's a bunch of kids practicing what we now know as heart rate variability biofeedback on Commodores. And Paul's an asthma expert. If you know anything about asthma, you know that asthma is a parasympathetic rebound effect. And so it isn't sympathetically mediated, it's parasympathetically mediated. So if these big peaks and valleys are stimulating the parasympathetic, we should be killing these kids, and yet they were all getting better. So he eventually got hooked up with a guy named Evgeny Vashilo, who was a Russian physiologist, and he was the physiologist to the cosmonauts. And so the anecdote that we like to tell is that he was watching one of his cosmonauts, Yuri, in space, watching his heart rate. Somebody's got to mute their phone, sorry. And about once a day, he would be watching Yuri's complex heart rate patterns, and he would see these big peaks and valleys for about 20 minutes every day. And so he got, first he didn't bother, and then he got concerned because who knew at that time what space sickness was going to be like. Says, Yuri, what's going on? I'm very worried about you. And Yuri calls down and says, shut up, I'm meditating. So it turns out he was a breath meditator, and here's what he was doing, the same thing we just saw. So our colleague Dwayne Eckberg, around this time, showed this effective resonance beautifully. He trained medical students to breathe at different paces, 24, 20, 17, and so on down. And they did this by, their average heart rate stayed exactly the same. So if you're looking at average heart rate, you wouldn't see anything. They were able to breathe at exactly where the peaks are. Those are the paces, exactly in hertz. And you can see they got a little peak. But when they get down towards the 4.5 to 7 breaths a minute here, those peaks got massively large. And Yuri, being an engineer as well, said, oh, there's only one way that can happen, and that is resonance. It's the actual physical characteristic of resonance. Here's what that means. You're pushing the kid on a swing. The resonant frequency of the swing is determined by the length of the rope. And if the input matches the resonance frequency, so you're pushing your kid right in line with the frequency of the swing, you get really good oscillations in the process of that. Now let's say you're doing this, but now your partner pushes back the other way. And what do? You get way bigger oscillations in that swing. So both people are pushing, but remember the person on the left has to push a little bit later than the person on the right. And so this is heart rate, this is breathing, and this is blood pressure. The inhalation of the breathing is the first thing that sets off the oscillation, and then the blood pressure kicks in from that higher heart rate and pushes it right back. And that explains why we get those big peaks and valleys. So heart rate variability biofeedback has shown to increase resting heart rate variability in normals and heart patients. This was never thought to be possible. Heart rate variability was thought to be an immutable reflex in the body. Nobody thought it changed except getting worse with age, or maybe getting slightly better with fitness. But we've shown time and time again, and Paul too, that people who train with this biofeedback technique increase their heart rate, their resting heart rate variability, just breathing normally, by 25 to 30% over the course of about 3 to 5 weeks. It seems to be accompanied by reductions of anxiety and depression, by reductions in cravings. We've so far studied alcohol, smoking, and food. It seems to improve the baroreflex in hypertensive and asthmatics, and even in normals, so that your baroreflex gets stronger. And as I said earlier, it seems to put some limits on sympathetic activity, especially in our pain patients that I'll talk about in a little bit. In asthmatics, it seems to reduce bronchospasm while improving lung function. And the new frontier is maybe inflammatory processes are affected. We have some preliminary evidence for that, but right now we don't have great evidence for that yet. Let me stop for a minute and see if there's questions on that.
Well, yeah, I do have a question. So when you're saying that it helps with asthma issues, I'm so used to doing a lot of deep breathing and relaxation, meditation stuff just because of insomnia issues. But when you have asthma attacks, it's like seems impossible to be doing the deep breathing.
Yeah, you don't do it during the asthma attack. You try to prevent the asthma attack by doing the breathing every day on a regular basis.
Okay, that makes more sense. Thanks.
And so what we think is that it reduces that parasympathetic rebound.
Okay.
That actually creates the asthma. Now, asthma is really an allergic reaction, no doubt about it.
Exactly.
But the inflammation and the allergic reaction are somewhat controlled by the parasympathetic nervous system. So if we strengthen that system, it appears to be quite beneficial. Paul has a number of very well-controlled studies with asthmatics showing very good results with asthmatics, and you can look those up if you're interested.
Thank you.
Other questions?
Can you say just a couple more words about influencing the inflammatory process? Can you say a little more about that?
Yeah, well, so there's a guy named Kevin Tracy, who is, let me see if I can get the, what am I doing wrong here? Enemy screen never mind. Who has been able to show that there's a cholinergic inflammatory component to the inflammatory system. It's getting recognized more and more now. And so the parasympathetic system plays somewhat of a role in the inflammatory system, especially in inflammatory overreaction. So, you know, many disorders we have, our inflammatory system is working too well, right? They overreact and create lupus, or they create some autoimmune disease. And asthma is probably one of those. So he's showing that is somewhat controlled by the cholinergic vagal system, and that perhaps anything that regulates that would have a positive effect on that. So there's a very recent review of that, more literature on that by Julian Thayer's group, in fact, that offers some potential. And in fact, there are some studies right now that are relevant to the current pandemic, where some people are monitoring their daily resting heart rate variability, not doing slow breathing, just measuring. And it looks like a drop in heart rate variability might be a very early sign for an inflammatory system that would be a sign of the virus, perhaps. It might precede temperature or anything else that you would see. So that work's going on right now. Whether it'll help us in this pandemic, probably not, but it's going on. So there's some interest in this. Right now, the data is still preliminary, but interesting.
Thank you.
Okay. So oftentimes people ask the question, well, why not just have people breathe at 6 breaths a minute? Why should we go through all this trouble that we're doing? And this is one of 2 or 3 studies that show that if you get the exact right breathing frequency, you get much better results than if you do it just at any old slow breathing technique. So it's a little bit of a plug for the biofeedback rather than just teaching people breathing techniques. Okay, so I'll come back to those slides in a second. Sorry, I realized I didn't put them in the right order. So let's go through the protocol as we think it should be done. The first part of the protocol is called finding resonance frequency. And this protocol is where the real biofeedback part of it comes in. You hook somebody up to something that measures beat by beat heartbeat. The best is a ECG. Can't do an ECG, then a PPG is acceptable. And you pace their breathing at some different paces. I like to do it starting at 7, or in kids a little bit higher, and then going down by half a breath for a couple of minutes at each breath. When I see the valley to peak amplitudes maximized, I see smoothness in the heart rate pattern, and I see the phases between breathing and heart rate going together, I'm honing in on what we think is the resonance frequency. It's really created by the blood flow in the chest and the relationship between their baroreflex and their breathing. So it's not a psychological factor at all. It's really a physical characteristic of the person. The thicker their blood, the slower it goes. The thinner the blood, the more it goes. If they're bigger, it'll be slower. If they're smaller, it'll be higher. Whatever it is, however, it looks like you got it. Once you're an adult, you've got it for life. So mine is 6 per minute. It turns out, and it's been 6 per minute for 20 years. It's never changed, and it never will change. Some of our kids might start off a little bit higher, and then when they mature, might go down a little bit. But for adults, it stays the same thing. The reason it does that is it's not a psychological or a stress-related phenomenon. It's a physical characteristic of the cardiovascular, cardiorespiratory system. So once we have it, and sometimes it takes 2 weeks to make sure we're getting the right one. But within 2 weeks, we're pretty sure we have the right frequency for that person. Then the important part of the treatment is getting them to buy into it, A, and B, getting them to do their homework. So once they've found the resonance frequency, we need them to practice 10 to 20 minutes a day at that frequency, and trying to get them little by little to use their diaphragm rather than their chest in the breathing. And to do that, we use a whole series of things that I'll talk about in a minute: apps, music, pacers, home trainers, anything that will get them to practice on a pretty regular basis. Once we've done that in our clinic, we then move to a little bit beyond that to if they're clients with psychopathology, with anxiety, we may do some acceptance commitment therapy or CBT, or in any case, we almost always put in some sort of mindful mindset. Our experience is, and we have a little bit of data for this, that when people learn to breathe at this resonance frequency, they find it easier to adopt a mindful mindset. I had the great experience of having a bunch of engineers from Qualcomm, is the biggest company in San Diego. These are computer engineers, many of them South Asians. And to them, the whole idea of psychotherapy, touchy-feely, is really not something they're interested in. These guys are a little bit towards the Asperger type of the spectrum. They're kind of these nerdy computer engineers. And they come to me because they've heard I'm not a touchy-feely psychologist. So I kind of overwhelm them with the technical aspects of biofeedback in the first couple of sessions. And they go home and practice, and they're getting benefit from that. And then after I really think they're practicing well, I'll give them a very mild, mindful instruction. You know, imagine there's a camera watching you. Can you put yourself in the place of the camera watching yourself? And inevitably they'll say, oh yeah, I can kind of do that. They don't consider it so flaky when we do it that way. So the tools we use to do this, there's many, many of them. This is an output from that Kubios program. Here's the website for it. You don't have to buy it's free if you buy the standard one, which is all you need. There are a bunch of other programs around trainers. The best home trainer probably is the Inner Balance by HeartMath, especially if you can get the person to not use their coherence measures, but to just use it in a way that we want them to use it with a pacer. Then it seems to give them feedback that works, but there are pros and cons to it. The cheapest, easiest way to go are just with breathing apps. This one is very easy, cardio, deep breathing. It's just set the pace, and then the little thing goes out and in, out and in. Another one that's a little more complex is breathe to relax, which gives you lots of options in the process of that. We have music available free on our website at our clinic at every one of the paces. We have 5 different sets of music at each pace. If you go to that website and click under the service, you can download into iTunes music that goes for about 10 minutes at 8, 7.5, 7, 6.5, 6, etc. And we find with the younger people, especially with their earbuds, they like the music. They can practice all different kinds of places. And they can close their eyes and practice as well, which is maybe somewhat of an advantage. We're right now, because of the virus, we're doing everything with this smartphone app. We like this one because it exports the data, but it only works for some people. So it's definitely, these smartphone cameras are very limited. But if you can get somebody with a nice solid pace on it, you can use, don't use their pacing, use your own. And you can kind of determine their resonance frequency from that and then give them an app to practice with. There's also other things like, there's the Inner Balance again. There's CoreSense has a finger plethysmograph. eSense has a chest strap. There's another one from England that has a little pacer for 150 pounds. There are new wearables out there now. They're not cheap, but they're coming along quickly. Some of them that are just built into the shirt itself. Some of them that are a paste on. And these are coming fast and furiously at this point. And here are a bunch of videos that I've made, and you can go, if I went too fast, you go back and see some version of this same thing somewhere else in the process of doing it. Let me go back to the slides I skipped. So one of the things we've realized now is, remember I said in the beginning that the 80 to 90% of the vagal pathways are efferent from the body to the brain. So as usual, Charles Darwin had it nailed. In 1872, he called what we call the vagus, he called the epigastric nerve. And he says, when the heart is affected, it reacts on the brain, and the state of the brain again reacts on the heart. So that under any excitement, there will be much mutual action and reaction between these, the two most important organs in the body. Imagine he got that in 1872. Amazing. So we now know that these afferent pathways, we don't know a lot about them, but we know that there are powerful afferent pathways, and it's led to a whole industry of vagal nerve stimulation industry, which is an invasive technique to try to do, I think, the same thing that we're doing. So what we've tried to do in our data is actually try to find out how that resonance frequency breathing is affecting the brain. So by looking at evoked potentials or fMRIs, and what we found is a dramatic effect on the brain. I didn't think we had time to go through that in this talk, but I have a ton of data on that. And it's really impressive how powerful effect on the brain it has. If you're a neurofeedback person, what you may not realize is that you've been filtering out heart rate patterns in the brain, otherwise you wouldn't see any EEG, it overwhelms them. When you take that filter off, the brain is bombarded by the ECG wave. And that pattern affects almost every part of the brain very dramatically. And when you do that at the slow breathing rhythms, the rhythms are really dramatic in the brain. And I could show you, if somebody wants to know more about that, I can pull up a bunch of slides on that. But just suffice it to say that this technique is profound in that it affects so many different aspects of our body and our brain. There's another little app that does this. So overall, heart rate variability appears to represent a promising biologically based intervention to improve resilience, autonomic flexibility, and stress management. Appears to affect homeostatic regulation by strengthening the baroreflex of the brain pathways, and doing so strengthening frontal inhibitory regulative functions. And my students got me this t-shirt, which is the best teaching eval I've ever had, probably. Let me stop the share, and I left the time so we can talk about some applications that you guys are interested in. Ahead of time, we knew there was some interest in pain, and in your world, this application for pain would be probably a welcome one. So let me talk about that a little bit, and then if you have some others you'd like to talk about, we can move into those. That accentuated antagonism idea that I said earlier is really the key to this. So what we've known for a long time, and the chiropractor probably can talk to his personal experience on this, because this came from me working with a chiropractor, close colleague. He was complaining that when he was doing trigger point releases, that in many people that it would be great, but as soon as they got back to their car after the session, their pain would return. And this was kind of the conundrum of the process that would carry on many, many more chiropractic sessions of trigger point release or massage. And so we came to the idea that, well, we did a whole bunch of research on trigger points and found out that trigger points are really sympathetically activated muscle spindles. So there's a whole bunch of research showing that the muscle spindle, the little stretch receptor in the muscle, is sympathetically activated, and that the location of the spindles, especially in the central muscles, in the head, neck, shoulders, very much matches where we find trigger points, Travell's trigger points. And so we wondered if we taught people this biofeedback technique, if when people were doing the releases, if they practiced daily and during the release and afterwards, and really got the technique down, if it would lengthen the length of relief coming from the trigger point releases. And this seems so, and so now we have data showing that that not only happens, but it's really dramatic. So the 2 or 3 hour time period of relief goes to 2 or 3 days almost immediately when people practice this, and very quickly kind of stretches out for long periods of time. This works great with massage, with acupressure, acupuncture, probably with craniosacral as well. I've always thought, when I had craniosacral done with me, I was quite skeptical about it because all the physiologists I know told me that the sutures in the cranium don't move. However, it felt great. And I paid attention to what the therapist was doing, and it was exactly at my resonance frequency, exactly at 6 per minute. So whatever that feeling that the therapists have holding the skull, they probably are tying into that resonance frequency. And so that's my guess is that's where part of the good results come from in the process of that. And you guys can yell at me if you don't like the physiology part of it, but that's what I think. But in terms of of trigger point releases, we have really dramatic results with that. And we think that basically what's happening is when people practice this on a regular basis, they accentuate that antagonism that keeps the sympathetics from reactivating those trigger points. And when you do that and you have a manual release of those trigger points, then that relief from that release really lasts a long time. So now I'll stop and let's talk about that a little bit. Go ahead if you have questions.
So are you saying whoever is doing the trigger point release on the person who is getting that therapy done on them breathes at their resonant frequency, and then that in turn makes the therapy last longer and have better results?
Right.
Okay.
So, and the way we do that usually is with the music, since it's hard to do a visual.
Okay.
If you if you find out what the resonance frequency is, download that music, put it on a little boom box in your office, get them breathing at that resonance frequency before you move into the release of the trigger point. And then do whatever technique you're good at. It looks to me like it works just as well for really good massage. The chiropractors seem to really have good trigger point releases in our experience. They've got magic hands. My friend Greg does better releases than anybody. And those releases, when we combine it with that, they also have to practice every day to get into the resonant frequency. But then during the session, it's who cares? I've never met a massage therapist or chiropractor who minds having that music on during the session.
Yeah.
It's a real easy transition.
Thank you.
Sure.
So you were saying that with the biofeedback, at first you notice it goes like into a 2 to 3 day period, and then it gets longer.
Yeah.
Maintaining in your system. How long do you see that going to?
Well, usually the cycle is broken. The same thing that you guys probably always saw when you treated people for weeks and weeks. Eventually, when you break the pattern of those trigger points, the cycle's broken, at least temporarily. We see that people do relapse, though, as soon as they're under a lot of stress or they do something physically to trigger that trigger point again. And then they usually just get a booster and come back and do the same thing, and they're fine again. So now we have quite a few long-term follow-ups of those folks, and they've all, most of the ones that we've seen long-term have learned to do it themselves with a lacrosse ball. Do their own trigger point releases after they've learned it with you guys, and so that they'll write me and say, oh yeah, I lost my lacrosse ball, I got to go get another one because that's really a lifesaver for me.
Good to know.
So I have a question. So I have colleagues that work with heart rate variability. I have a close friend who's a cardiologist who loves working with that with his patients. So this is newer for me. I mean, I know about it, but just learning. Do you recommend Inner Balance by HeartMath? I mean, I just want to start working with it and heart rate resonance and so.
Yeah, so Guy and I were talking about this earlier. So there is some, it's a mixed bag. So in terms of an inexpensive device that works really well, Inner Balance works great. I would not spend any money on the M-Wave when you don't really need to. And the Inner Balance works just as well, especially on an iPad. It gives you a really nice picture on an iPad instead of a phone, but it works great on the phone. Working great means that it usually is pretty good at finding a pulse. However, 15% of people, you can't get a pulse for them. They get very frustrated. But if you can find a nice pulse and you can tell them to basically ignore the coherence meter and just pay attention to the heart rate patterns and help them find their resonance frequency, you can do it with this one as well. And the M-Wave, the Inner Balance will export your IBI data, and you can put it in Cuvios and do all those things I talked about before with it just as well. And then let's say you discover they're a 5.5 or 6 or 6.5, and they're now practicing that. If they want to practice at home, then they practice with the Inner Balance, setting their breathing pacer with either music or on the device itself to 6.5. And all they're going to see for feedback is their heart rate pattern going up and down with their breathing, right? And the coherence lines are too easy to get to go up. So both Guy and I have had the experience of people going home and practicing for a long period of time with the Inner Balance and not getting any improvement in symptoms because it was too easy to get coherence to go up. Coherence really is the right, what they call, it's not the right term, it's a term they made up, but it's really resonance frequency. And if you happen to hit it right, then that's fine, but a lot of people don't quite get it from that. And also they spend a lot of time talking about positive emotions, which are great, but they don't do anything for heart rate variability. So you want to keep that as a separate issue. If you want to use positive imagery or anything else, do that as a separate intervention. Because when people do positive imagery, they often get worse heart rate variability. Because we were talking about earlier, if you've got a monkey brain like mine, and I start to think about something wonderful and relaxing, like I'm a sailor, so I think about being out again when this stuff breaks out sailing in a beautiful day. Immediately my mind goes to whether I should tighten up the jib a little bit, and maybe that telltale is not as good as it should be. And so that lowers my heart rate variability. That's not good for me. So if I just focus on mindful breathing, I'm good. That's what I keep on coming back to. So yeah, so I think that for a home training, or if you want to use it as a clinician, that's the cheapest alternative right now. The other disadvantage of it is that you don't have respiration, right? All you see is heart rate. So with the Nexus or the devices, the other more expensive devices, you get a respiration wave going together, and it's really easy to teach the biofeedback with that because, like from kids, we tell them make the dolphins swim together. And they totally get that. But nevertheless, it can be quite effective if that's all you've got and you want to use that in the process of doing it. Try to learn to use it that way.
Thank you.
Sure.
I just wanted to add in, around that. So there's as wonderfully simple as heart rate variability can be, in the sense of like 6 breaths per minute is kind of this average, and you can just say to somebody, here's a free breath pacer on your smartphone, go for it. And there's value there. But that goes all the way to like a full, clinical resonant frequency determination with a full biofeedback setup where we're monitoring maybe 3 to 6 different biometrics at the same time and doing a statistical analysis on all of it, and then treating somebody with that same equipment. So you're watching what's happening, as much of their autonomics as we can watch, and to see that does their resonant frequency really optimize at 5.5 breaths, and does their skin conductance and their temperature and everything kind of move in a positive direction? So you've got this full breadth of free app, breathe at this pace, it's good for you, to a clinical intake. And so there's value on that whole spectrum. And I think that's one of the things that I really try and get across to clinicians and patients is there's value everywhere along there, but the value isn't equal. And so you kind of get into the process at whatever level with the understanding of, you're getting the value at the level that you're buying in at. And the other thing is, of course, people aren't all the same. So you might have somebody with a relatively minor, hiccup in their system, and they only need a simple intervention. But you might have somebody with a really significant dysregulation, and chances are that person isn't going to respond anywhere the way you want to with the free Breath Pacer app. And so I think you kind of need, it's helpful to look at all of that, the patient and their level of need and intervention, and the intervention itself, and kind of bring them together. Because my experience is kind of, if that doesn't happen, then we introduce HRV to people and they have no response, or worse, they have an abreaction, and then we blame it all on HRV. So Phil is writing me a question here. Let me jump to that. Okay, so this is what I mentioned to you earlier, Dr. Gevirtz, that Phil's a gastroenterologist, and he's got a question for you about HRV and irritable bowel syndrome. And I know you and I earlier, we talked about pediatrics and just abdominal pain, so a little bit more general. But if you want to maybe kind of take a swipe at both of those. So irritable bowel as a specific diagnosis, and then just abdominal pain in pediatrics.
Yeah, so that's great. Yeah, so it's too bad your audio's not working. So what we found is that gastroenterologists are our best customers. They totally get brain-gut connection, autonomic connection, right? It's all part of your training. It's all part of what's done. So in treating functional abdominal, any kind of functional abdominal pain, IBS, abdominal pain in kids, nausea, functional nausea, diarrhea, constipation, bloating. What's happened is we've partnered with our children's hospital here. There's a wonderful head of the pediatric gastroenterology named Dr. Hayat Musa. She came from Nationwide in Ohio. We were really lucky to get her. And the gastroenterologists are our best customers. They totally get it. They send us every kid, and there are thousands of kids a year with these functional abdominal problems. Our children's hospital gets about 3,000 a year. So we get about 5 referrals a week. And they come in every variety. They come from kids with wonderful, healthy families, and terrific, healthy kids, but still just have the vulnerability. They tend to be a bit anxious or a little bit too perfectionistic. And they come from horrible developmental histories and terrible families, both. So we get a whole range of them in the process. But what we found is that the biofeedback technique is the entry technique for all of them, is really effective. And for a fairly large percentage, it's all we really need to do with it. We teach them the technique, they get them practicing. We really got to get the parents to buy in, which is a big problem with the kids, but you've got to get the parent to buy into it. And that's where biofeedback, as Guy was saying, really comes in handy. We kind of overwhelm them with a lot of technical stuff that makes them think that it's more than just slow breathing. And then we get these fantastic results. So we published one study, just a case, 28 consecutive cases of kids and adolescents. We actually get more adolescents than we do children. And 20 out of 28 were significantly better. 70% of them were completely symptom-free. And the other 30% were just better. And that's, we really, if we don't get good results with those kids, we're really disappointed. Now with adult IBS, it's a little trickier. And again, it depends a lot on the comorbidity with psychopathology. But if we get an adult in with IBS, and that's the primary complaint, they don't seem to have a ton of other psychological problems, we usually get good results with them with just the practice of the biofeedback, without any psychotherapy, without any other adjunctive techniques. If they're a little bit more complex, then we actually add in CBT or ACT and some mindfulness techniques as well. And then those folks take a bit longer. The kids, we usually only see them 4 or 5 times and they're better. The adults with IBS range from 4 or 5 sessions to months, depending on the overlying problems that come with it. But as Phil would tell us if he could talk, would be that the gut is heavily regulated by the vagus. So in normal situations, that vagal activity in the gut affects the myenteric plexus dramatically. And once you get a disruption of serotonin, the myenteric plexus, that layer of the gut becomes extremely painful to stretch. So if we get somebody in who has the really classic IBS with constipation and with relief, and their pain is relieved by a bowel movement, and they are an internalizing kind of person, they tend to be a bit more anxious than the other. And we use the biofeedback, we almost always see really good results with those folks. And they understand that what we're doing is regulating that hypersensitivity to stretch in the gut, at all levels of the gut, that all the studies have shown to be the source of the pain, and also changing motility. So right now we're doing a really interesting study. One of the postdocs at UCSD came up with a non-invasive electrogastrogram that measures gastric motility through surface electrodes. It was written up in, I think, Lancet or New England Journal of Medicine. You could look it up. Dr. Musa is also on that paper. And we're now testing these kids with pre and post testing of our treatment to see if we're actually affecting motility with the biofeedback. We think we might be, but we don't know that yet. But I mean, it's really exciting that they can look at this non-invasive motility measure in doing it. So this is a real exciting area. I'm really always happy to talk to anybody. It's interesting that very few psychologists or social workers seem to deal with this problem as much as they should, because you know that it's incredibly prevalent and really prevalent in primary care. And when I go talk to primary docs, they usually leave the room and come back with the file folders to give me for these folks that want to get rid of them.
So Phil had a follow-up comment and question. There are a lot of patients with constipation who have non-relaxation of the pelvic floor. He says, I suspect HRV would be helpful for them too. Do you agree?
Yeah, for many of them it is. We definitely do see some constipation patients who don't respond. They practice, and they like it, they're less anxious, everything is good, and their constipation is still pretty much dependent on Miralax still. So it's obviously something more complicated than we know about, but if we the ones that we seem to hit the right mediator respond really well. And oftentimes they'll call back into us and say, I stopped practicing and I came back and now I know I need to practice. And that's great. We really know we got it from that. I think I told Guy, Phil, if you want to chat separately, I'd be very happy to talk to you at any point. So I think my email, Guy's got my email. So just let me know.
I'll do an email introduction between the two of you.
Okay.
And I don't know. I don't want to put Dr. Cinda on the spot, but I'm going to. I don't know, Dr. Cinda, just in terms of your own practice, the population you work with, if if there's some questions percolating on your side, or if you already have a clear sense that starting tomorrow you're gonna be prescribing HRV. But
Well, I mean, the applications sound very intriguing, and I mean, and I think I've been absolutely fascinated about the vagus nerve since I was a med student, and I literally remember thinking you could spend your whole life and then probably several lifetimes studying the vagus nerve and still not understand it. So, and I've been through myself treatments for SIBO and gotten some vagus nerve treatments, and you know, it was life changing, honestly. And I've heard that from several people. So finding out that you could tap into this in a somewhat of a low tech way is, I'm just extremely interested.
Yeah, I had an at that conference I was talking about in Vegas. Had an interesting experience. There's a guy from Wayne State, Dr. Saba, who has done a lot of the work on vagal nerve stimulation, stimulating that afferent pathway of that vagus nerve, especially in congestive heart failure. Right. So we had just finished a controlled study in congestive heart failure, in which we one random controlled trial, and one group got the HRV and the other group get treatment as usual. And the improvement in the 6-minute walk was exactly the same as the vagal nerve stimulator that he was getting with his study. I thought he'd be thrilled to know this. He wasn't so thrilled because he was heavily invested in this device. But we've seen we actually been following the vagal nerve stimulation research closely, because we have a couple of studies showing, and I didn't show them today, but showing how powerfully that during the resonance frequency, what happens in the brain by way of that vagal afferent, it is really dramatic. And I'd be glad to share that with you if you want to see it at some point. But we have a lot to learn, you're right, but it's an interesting area.
So if somebody has a question, jump in. Otherwise, I'm going to just maybe ask one last question here, and then we can wrap up. Well, so first I'll just say for myself, I would be delighted to have you back and do one that's more HRV in the brain, and just kind of go deep into that. Obviously, doing neurofeedback, that's high on my list of interest. But I'm wondering, just part of the what's happening today, in the world with Corona and people kind of at home, social isolation. Talking with our mental health providers, they're seeing a great amount of need in their patient population, anxiety. I would imagine to somewhat equal degree depression, or just even if we don't say anxiety, depression, we just say level of dysregulation. So what do you see in the research for HRV and, again, anxiety, depression?
Yeah, so we've had many studies. There's a meta-analysis on it as well. We just finished 2 more studies where we used HRV in conjunction with other therapies for depression. We always get really good drops in depression when people do this, sometimes just by itself, but usually we combine it with some other therapy. In one case, we looked at depression following a myocardial infarction, and everybody was on Zoloft, right? If you go into the cardiologist and after you've had an MI and you look sad, they give you Zoloft because the drug reps have convinced them that's the drug they should give them. And it has it has these mild effects. It brought down the Beck depression from 32 to 27 Zoloft. But when we combined it with HRV, those 27s went down to 7 and 6 on the Beck. Whereas the Zoloft just leveled off in the low 20s. So we've had really good examples of that with anxiety and depression using it. Whether that would be something in this kind of situation, I don't know. One thing I've thought of with the access of these social media things is that in our pain unit in our big hospital here, we do biofeedback in groups. And there is definitely something to the social connection that people get when they do this together. They're breathing at their own pace, but they're still working with other people doing it. So I'm wondering if, we should be organizing groups just like this, where we're all sitting around with our own music, doing HRV and then sharing the result. I think Porges and his wife Sue Carter would say that would promote connectivity, human connectivity. So who knows?
Social engagement system.
Right. And whether it works through Zoom or not, that's something we don't know, but it probably does.
All right. Well, if there's nothing else,
I just had a comment.
please.
Maybe that explains why meditation works better in a group than by people by themselves.
I think most everything works better in groups than by themselves. People, we did a study. We did a HRV compared to yoga study for fibromyalgia, but both of them were done in groups. And when we kind of looked at the group effect compared to the individual intervention, both of them worked great. There were no difference between the two, but the groups were so bonded that they paid the instructor to keep on going after the study was done, right? And I think most of them would say that it was the group bonding was more important to them than any of the interventions we did. So, especially these were severe, middle-aged women with severe fibromyalgia. And if you know anything about that disorder, it's a horrible stigmatizing disorder. Nobody in the medical world wants to deal with them at all. So they found a lot of support in each other, and they did a lot better. I have lots of slides on that too.
All right. Well, I think we're there. I want to say thank you, Dr. Gevirtz, for making time to talk with us tonight. It was delightful. Appreciate you sharing your wisdom and experience.
Okay, be safe.
Thank you.